Welcome to Module 13, Nursing 542. This week's module addresses the management of musculoskeletal conditions in the primary care setting. Most musculoskeletal injuries can be treated conservatively with the old RICE, rest, ice, compression, elevation. Far too many people underestimate, in my opinion, the anti-inflammatory effects and analgesic effects of icing an injury. Be sure to instruct patient on the need to protect the skin when icing an injury by keeping the skin covered and avoiding direct contact between the skin and ice. If there's no contraindications, you can add non-steroidal anti-inflammatories to the treatment in the acute phase. Encourage the patient to take with food and discontinue should GI symptoms occur. Avoid NSAIDs in people with hypertension. Again, RICE is a recommended conservative treatment for bursitis as well, for many musculoskeletal injuries or complaints. Some providers aspirate the bursa fluid to relieve pressure. However, I would recommend that you avoid doing that due to the risk of infection and because it typically just reoccurs rather quickly anyway. The only time I would aspirate the fluid is to rule out infection. Protecting the area with knee pads is also appropriate, obviously if it's at the knee, elbow pad if it's at the elbow. It's also appropriate if the patient cannot avoid the aggravating activity, but ideally they should avoid the aggravating activity until the bursitis resolves and then utilize protective padding to avoid recurrence. Never aspirate or inject a joint in a patient with a prosthetic joint. If the patient has bursitis type symptoms over a prosthetic joint, you will want to get them to their orthopedic surgeon ASAP, as they may have an infected prosthesis which requires urgent tendinitis management. This is a little bit of a twist on the traditional RICE. This is what the Kennedy text has, the Price MM. The key here is finding the right balance between maintaining range of motion and not further aggravating the condition. Depending upon the patient, you will have to stress the importance of either avoiding aggravating activities or maintaining function. For example, I've had multiple weightlifters who do not avoid any overhead lifts as advised and then seem perplexed when their symptoms don't improve. On the other hand, pain will often cause patients to overprotect and immobilize the area, and range of motion can be compromised. An elbow or shoulder can freeze up after a relatively short period of immobility. In patients where there's concern about this, I would be sure to instruct them to do range of motion exercises, TID, for example, like pendulum motions with the shoulder while flexed at the waist, or simple flexion extension of the elbow. Bracing is specific to the area involved, obviously, and some are more successful than others. For example, a band worn distal to the elbow relieves epicondylitis quite successfully by decreasing the tension on the tendon. Referral to physical therapy is appropriate both for modalities such as massage or electrical stimulation and for exercises. Corticosteroid injections are frequently utilized for tendinitis. However, you'll want to receive specific training to perform those. Injecting directly into a tendon can lead to rupture. Contraindications for injection include infection, fracture, and prosthetic joint. As mentioned in last week's lecture, fractures may not be visible on initial x-rays. If the exam is clinically suspicious for fracture, then treat it like one and refer to an orthopedic surgeon, even if the x-ray doesn't reveal a fracture. Open fractures are emergencies, as is any fracture with neurovascular injury. Other fractures can be treated with a soft splint, meaning that the splint does not enclose the entire circumference of the bone, or if it does, it is adjustable. This is very important in the acute phase to allow for swelling and prevent neurovascular injury compartment syndrome. This temporary splint should immobilize the joints above and below the fracture site. All patients should be referred to an orthopedist and seen within 3 to 4 days of injury. All patients should be educated on RICE treatments and the need to seek urgent care should symptoms of compartment syndrome such as intense increase in pain, hypoesthesia, paresthesia, weakness, or paralysis occur. Long-term immobilization will be performed by the orthopedist, meaning casting, splinting, traction, or surgical intervention. In the primary care, the role after the initial acute diagnosis and referral is to monitor for complications such as compartment syndrome, DVT, pulmonary embolism, infection, anemia, that may occur, all depending upon the mechanism of injury and type of fracture. You'll want to provide patient education regarding fall and injury prevention as appropriate, again depending upon the cause of the fracture. If the fracture occurred with a ground level fall, then you should assess and treat for osteoporosis accordingly. Many patients will require physical therapy to rehab after a fracture treatment and extended immobilization. Orthopedists may very well, most likely, order the physical therapy, but you'll want to instruct the patient on the importance of follow-through and compliance with home exercise programs and activity restrictions. And the treatment of gout, rest, limit weight bearing, oral hydration up to 3 liters a day if not contraindicated, avoid alcohol, and low purine diet, non-steroidal anti-inflammatories, corticosteroids, and oral colchicine have potential side effects, particularly for the patient populations that are frequently diagnosed with gout, such as those with renal insufficiency, diabetes, and hypertension. So proceed with caution and monitor closely. Patients should return to clinic for recheck 72 hours after initial diagnosis or treatment initiation. Gout is considered chronic if they suffer 3 or more attacks in 1 year. And at that point, that is when you definitely treat with the urate lowering medications. Serum urate levels are utilized to monitor chronic gout long term. You'll want to refer to a rheumatologist any patient requiring joint injections or aspiration, experiencing complications with treatment, or with an unclear diagnosis. As primary care provider, you'll want to assess patient for conditions associated with gout, such as kidney stones or progressive renal failure. Untreated chronic gout can cause disabling joint destruction. Patient education regarding lifestyle changes, alcohol, smoking cessation, weight loss, low purine diet, and avoidance of diuretics. The majority of low back pain improves within 1 to 4 weeks. Even with a herniated disc, which, remember from last week's lecture, was noted to be present in approximately 30% of the general adult population, conservative treatment is generally effective. Because of the potential complications associated with bed rest, patients should be encouraged to limit restricting mobility to 2 days maximum. After the acute phase, all patients should receive instruction on an exercise program. If you feel comfortable doing that yourself, or you can refer to PT. Many patients with low back pain or overweight would benefit from a weight loss program that would ultimately ease their low back pain. As you can just picture with a large belly, what pressure that puts on the low back. Non-steroidal anti-inflammatories and muscle relaxants are frequently prescribed for low back pain. Unfortunately, so are opioids, but they should be avoided if possible, if at all possible, and utilized for only short, acute time periods, if at all. Patient education on proper body mechanics, good posture, supportive footwear, as well as the importance of a long-term, regular, consistent exercise program, and treatment options, and frequency of herniated discs. Those are all topics that should be covered in your patient education. If patient does not respond to conservative treatment, a referral to a physiatrist or orthopedist is appropriate. They may treat with epidural steroid injections or surgical intervention. Osteoarthritis management. The goal of osteoarthritis treatment is to relieve symptoms and maximize function. If the osteoarthritis is such that it keeps a patient from being active, then multiple comorbidities related to sedentary lifestyle may develop. Exercise is key to maintaining both overall health and range of motion in the affected joint. Non-weight bearing, such as swimming, stationary bike, tend to be most tolerated exercises. Obesity increases joint load and decreases activity, so weight loss may be an important aspect of osteoarthritis treatment. The various medications typically used with osteoarthritis are listed here and described in more detail in our text. I would encourage you to avoid the use of opioids if at all possible, as if and when they proceed to go on for surgical treatment, post-operative pain control is extremely difficult in a patient who's been utilizing opioids preoperatively. With specific training, primary care providers can perform intra-articular injections, which typically provide 3 to 6 months of relief, but they cannot be done, over and over or indefinitely. Typically only twice a year and 3 to 4 times. Intra-articular hip injections can only be done under imaging, so that's something that you'd need to order done at an imaging center or hospital. Typical course of osteoarthritis is good days and bad days with gradual worsening over time, fewer good days and worse bad days. There are multiple orthotics that can be utilized, such as unloader braces, etc. I've not seen them be extremely effective. In patients with severe comorbidities, total joint replacement may not be an option, but for others it will bring a welcome relief of symptoms and a return of function. As primary care provider, you want to provide relief of symptoms, monitor for side effects of treatment, and keep your patient as fit and healthy as possible so that if and when they undergo total joint replacement, that they have the best possible outcome. Polymyalgia rheumatica, PMR. Remember from last week's lecture that PMR is diagnosed based on clinical response to treatment. Treatment is typically prednisone, which may last for months to years, with gradual tapering once the symptoms have resolved and labs have normalized. You'll want to monitor for side effects related to prednisone, checking urea, electrolytes, and glucose every 3 months while on prednisone. DEXA scan should be performed, as osteoporosis is a concern with long-term prednisone use. Prophylactic treatment with vitamin D and calcium supplementation and perhaps bisphosphonates should be considered. Close monitoring of symptoms and labs are required. Initially, labs will be checked every 2 to 3 weeks with gradual spacing to 3 months. Patients with giant cell arteritis need frequent eye exams, and because they are at risk for aortic aneurysm, abdominal examination is necessary. Patients should be educated regarding signs of giant cell arteritis. As untreated, it may result in blindness. Education regarding risks associated with long-term corticosteroid use, such as diabetes, peptic ulcers, weight gain, infection, needs to be provided to the patient. Smoking cessation counseling should also be provided. Referral to ophthalmologist and/or rheumatologist may be appropriate if patient exhibits visual symptoms or does not respond to treatment. The diagnosis, again, for the PMR is some response in symptoms within 24 hours of initiation of treatment with prednisone. And then the lab work typically begins to normalize within 7 to 10 days. Rheumatoid arthritis management. Constitutional symptoms may include low-grade temp, weight loss, malaise, and depression. Rheumatoid arthritis morning stiffness generally improves over the course of the day as compared to osteoarthritis stiffness, which gets worse and recurs throughout the day with inactivity. Rheumatoid arthritis pain is typically present regardless of weight bearing or movement. Rheumatoid arthritis treatment, the aim is to halt or slow the disease progression, relieve symptoms, maximize function, as there is no cure. I would personally refer any newly suspected rheumatoid arthritis patient to a rheumatologist. New disease-modifying anti-rheumatic drugs are coming on the market every day, it seems. As primary care provider, you'll need to assess for side effects of those medications, of which there are many. Educate the patient on the disease process, medication options and side effects, importance of exercise and rest in their daily routine. Typically, a team of primary care rheumatologists, physical therapists, and occupational therapists will be involved in management of rheumatoid arthritis. And again, I know that we have covered a ton of information this week. And please let me know if you have questions under the course communications tab, and I'll address them there. Thanks. Have a good week.